Hello, everybody. Good morning from Iowa City. It's 10 a.m. here, and good afternoon in São Paulo, Brazil. It's 1 p.m. My name is Alexandre Marra. I'm a professor of post-graduation stricto senso program in health sciences at Albert Einstein Instituto Israelita de Ensino e Pesquisa. I have been doing research at the University of Iowa of Internal Medicine Department in Iowa City for 6 years. I'm really excited to introduce the second presentation in Einstein Connection series of guest speakers. Last month was the time of Dr. Elisa and their students with wonderful thoughts. Einstein Connection is our international program that intends to connect Brazilian researchers, students, and healthcare personnel with international professors and international researchers. It's my pleasure to introduce our guest speaker, Dr. Eli Perencevich. He is the Associate Chair for Clinical and Health Services Research and Professor of Internal Medicine at the University of Iowa, Carver College of Medicine. Dr. Perencevich is also the Director of CADRE, the Center for Access and Delivery Research and Evaluation at the Iowa City VA Medical Center. He also serves as the Associate Editor for Infectious Disease for JAMA Network Open. I have been honored to have Eli as one of my mentors at the University of Iowa, and it's been rewarding to collaborate with Eli on a couple of research projects. He'll talk to us about infectious disease epidemiologist life from VRE to SARS-CoV-2 in the Veterans Health Administration. We have planned for Dr. Perencevich to speak for 45 minutes, after which we will have 10 to 15 minutes to answer questions. You can unmute yourself and ask your questions after Eli's talk, or you can type your question in the chat. I'd like to ask for all of you to answer the survey at the end of the presentation. Thank you very much, and I now hand it over to Dr. Eli Perencevich to start. Thank you. Eli.
Thank you, Alex. And I've really enjoyed collaborating with Alex here. I don't see myself so much as a mentor as a collaborator. I learn a lot from him as well. So it's been great to have him here. And hopefully we can build collaborations with you in Sao Paulo in Brazil more in the future, because I think this is where we need to go. And I'll talk a little bit about that. So thanks for the introduction and the opportunity to speak to you today. So I have to start off by mentioning my conflicts of interest. I don't have any industry conflicts. As Alex mentioned, I'm associate editor at JAMA Network Open, an open access journal, part of the American Medical Association journals. And I have US federal grant funding, mostly from Veterans Affairs, but also recently from CDC and AHRQ. And I'm a US government employee, but nothing I will talk to today is on their behalf. These are all my opinions and don't represent the opinions of the US government. So when Alex was asking me to give a talk, I mentioned that I've been, I kind of prepared this talk recently to kind of think about my career and how I ended up where I was. And so we thought this might be useful. So hopefully it's useful or interesting to you, but I will be talking about my early career, why I ended up as an infectious disease epidemiologist. I think when we're thinking about our lives and big decisions and where we want to end up, we should really ask the first question is why? Why are we doing this? You know, why do we want to do what we're doing? And if you understand the why, then you can figure out what to do after that. And so I'll explain that a little bit. And then talk about my research in the VA, the Veterans Affairs National Healthcare System, some collaborations with CDC, Centers for Disease Control, and specific pathogens, MRSA and gram negatives, and of course, COVID-19, and some new antimicrobial stewardship studies that I've collaborated on with Alex. So I did want to start off, I probably should put her picture up here, but I've had a life mentor really since medical school. June Osborne actually was the mother of one of my best friends in medical school. We were also at the same undergraduate institution at Michigan, but at Case Western Reserve, where I went to medical school, I got to meet Dr. Osborne. And so she's still alive. She's still living in Washington, DC area, and is infectious disease virologist who trained with Fred Robbins, who at the time was the emeritus dean at Case Western Reserve University, where I was in medical school. But he was one of the Nobel Prize winners for culturing the polio virus, which led to the polio vaccine. And Dr. Osborne was dean at School of Public Health of Michigan. When I met her, she was chairing the National AIDS Commission for the first President Bush. And I just put on this kind of nice letter, but she was the advisor to Magic Johnson, the famous basketball player, when he first got HIV. And so I watched her public health life, infectious disease life, and I think that's why one of the reasons I wanted to become an infectious disease physician and ultimately epidemiologist because of Dr. Osborne's influence. And then the other why was when I was in medical school, and particularly in residency, was the peak of the HIV epidemic in New York City and really in the world, definitely in the country, and eventually the world. And you can kind of see there, I was there in the early 90s at New York Hospital, and it peaked in 96, roughly, the cases. That's when protease inhibitors were developed. But throughout my early formative years, there really was the HIV pandemic. And so during this time, my mentor, who's a pretty well-known infectious disease physician, especially in New York, Ken Sepkowitz, also studied healthcare-associated infections and really encouraged me to work in that area too, not just HIV. So another mentor of mine, but really seeing what happened with HIV made me realize I want to dedicate my life to infectious diseases. And then really, I was thinking back, why did I end up becoming interested in infection control? And when I was a resident in the 1990s at Cornell New York Hospital, they had this policy that you had to change a central venous catheter every 3 or 4 days. I can't remember exactly, but I think it was every 3 days. And you were allowed to change it once over a wire. And I remember having to do this as an intern and resident on all my patients. And if you've ever had a central line, these are incredibly painful to put in. A fresh stick, you risk a pneumothorax dropping their lung. And I didn't know if there was any data. It seemed kind of useless. And I started looking into it and trying to change things. And there was this wonderful nurse, Mary, who's from Ireland. I think she was over 6 feet tall, 2 meters tall. She was far taller than me. And she would kind of tower over me. And when I would try to change things or change policy, she would say to me, Eli, what does it say to you when you walk into the hospital every morning above the door? So when you walk into this is New York Hospital here, above the door, there was a sign. And so the next day I read it, and it said, founded by King George III. That was the king who oversaw the US colonies before our independence. And it's founded by King George III in 1771. And so the next day I told her, I said, well, Mary, it says founded by King George III in 1771. And she said, Eli, this hospital's been around for, the 250 years. Why do you think you can change anything in the hospital? And so she was right. I couldn't change anything necessarily in the hospital, but I kind of had a mission then. I wanted to figure out how to change or improve healthcare. So that's how I became very interested in when I applied for a fellowship, getting a master's degree and figuring out how to do science to change practice. And interestingly enough, when I was looking at this, there was a very famous paper in the New England Journal published by Barry Farr's group, who was at University of Virginia, a very famous infection control doctor who's unfortunately since passed away. And he did a randomized trial of 4 different strategies. You can change the line every 3 days or as indicated. And then in like a 2x2 table, sometimes they were changed with a guide wire and other times they were inserted at a fresh site, at a new site. And they reported that if you changed over a guide wire, you had more infections. So they said, don't use a guide wire. So we don't really do that anymore. And changing at a new site was associated with mechanical complications. So you would have a pneumothorax or bleeding or other issues. And interestingly, there were no more infections if you routinely replaced the catheters every 3 days, or if you just waited until there was an indication. And so this suggested that the quote here, routine replacement of catheters every 3 days does not prevent infection. So this is how you change practice. You do a clinical trial and you figure it out. And so that's why another, kind of what really motivated me. So after residency, I went to fellowship at Beth Israel Deaconess in Boston. And got a Master's of Science at the Harvard School of Public Health. And I'll show the 2 papers. I worked on a surgical site infection project with 2 mentors, Ken Sands at Beth Israel and Richard Platt at the Brigham. And then a math modeling paper with Mark Lipsitch and Milt Weinstein at the Harvard School of Public Health. And these are 2 papers I published as a fellow. Again, I'll spend a little bit of time on the first paper, the model, just showing that for a second. And then we did a matched cohort study where we estimated the costs of surgical site infections. And just briefly, I don't want to spend too much time on specific papers I've worked on, but this was a mathematical model where we simulated in the computer what would happen in a 10-bed ICU if we did active surveillance, so swab everyone on admission, and then isolate those that were positive, or isolate everyone immediately. And then if the culture comes back negative, the perirectal culture swab comes back negative, then, we would stop isolation. And we compared that to passive surveillance, only isolating those where we found a clinical culture and no surveillance at all. And in this table, you can see, I think I can bring up a highlighter. So if we did nothing in a year, there would be 118 VRE transmissions in the mathematical model. And then if we only isolated clinical cultures, we prevented very few transmissions. And that's because there's about a 10-to-1 ratio. Clinical cultures only pick up 10% of the colonized patients, so you miss a lot. And then active surveillance, where you isolate in 48 hours when the culture becomes positive, this is before rapid testing, you would have 72 cases. And if you isolated everyone and release them from isolation, from contact precautions, there would only be 41 cases. And so passive surveillance prevents 4% of cases, active surveillance 40%, and active surveillance coupled with immediate isolation presented 65% of cases. Percent of cases. And so, it's a fun paper, it's a mathematical model, but what really made me happy. So as I showed you before, Barry Farr wrote that really important clinical trial and was kind of a hero of mine, and one of the reasons I wanted to go into infectious disease epidemiology. On this, one of my first ever papers, he wrote the commentary in clinical infectious diseases. And it was a really nice commentary. I mean, he pointed out the strengths and weaknesses and his understanding. But this quote really made me happy. I'll always remember. He said, the article by Perencevich has the potential for moving the infectious disease and infection control communities closer to a tipping point on the control of this important pathogen. And so, that's pretty cool early on in your career to have your hero write a commentary. and then you know, say such nice things. So another motivating factor that I was kind of doing the right thing for me. After fellowship, I became a faculty member, assistant professor at University of Maryland of Baltimore. I was there for 10 years, became an associate professor. I was the hospital epidemiologist at the University of Maryland Medical Center. I worked with many colleagues, Anthony Harris, who's still there, Mary Claire Rogman, Dan Morgan, Carrie Tom, JJ Fruno, Justina McGregor, these really wonderful folks. And Anthony Harris built a central data repository. So it's something we're working on even now at Iowa and collaborating with Alexandre to kind of merge data, which I'll talk about. But this was really important. I mean, we had 10 years of our hospital data we could analyze and publish on. And so that led to a lot of grants that you'll see there. And then 10 years in, I realized that as a VA funded investigator, I was kind of all by myself at the University of Maryland. There weren't many health services researchers. And so I moved to the University of Iowa to join what was a different center, but eventually became our COIN center, CADRE. And now I direct CADRE, and I'm associate chair of clinical and health services research at Iowa. And I've been here now 11 years. So health services research is a big part of the Veterans Affairs system. It's the only national healthcare system in the United States. It's for our military veterans. It's has 171 medical centers, 132 nursing homes, over 1,000 outpatient clinics, and there are 9 million veterans in this national system. And it has a centralized electronic medical record, and that's kind of the basis of most of the research our group does, is we query and analyze that national database. And VA HSR&D supports 19 centers of innovation, and that's where the kind of the centers of research are in the VA, and CADRE is one of those centers of innovation. This is a picture from a few years ago before the pandemic of the investigators and staff in our center in Iowa City. So to talk somewhat about the research we're doing in CADRE and that I've collaborated on, I'll do that next. So one of the, I think, most important things in retrospect we did was about 5 years ago, we decided to bring a group of people from across the country. These were all VA investigators, both physicians and PhD and PharmD investigators, to Iowa City to set a research agenda for tackling the multi-drug resistant organism crisis in the VA. And so we in September 2016, we brought 37 folks from across the entire country. And we published 5 papers. This is the overall agenda, but then we had 4 other papers looking at transmission prevention, things like hands hygiene, contact precautions, antimicrobial stewardship, the microbiome, and then special populations. We have a lot of spinal cord injury patients and nursing home patients. And so we had a special research agenda for those. And this has really set us up really nicely, because we could reference it in our papers and grants and point out that the research we're doing fits this model that we and an agenda that the entire VA feels is important. From these collaborations, we developed a research network. So from 2017 to 2019, right up until when the pandemic hit, we had a 15 VA hospital, and you can see the stars there. So pretty much the whole country was represented with sites. So 15 VAs were in the network, and there were 8 nursing homes, that's the CLC, and 15 university hospitals. So 38 facilities were in this network, and it was funded by both CDC and the VA. And we had a central IRB. So any trial we only had to do one IRB for the entire network. And we, the grant funded or the support funded research coordinator at every single facility. And then we had a coordinating center and data management and qualitative implementation core based in Iowa City. So a lot of investment in our people that are really the infrastructure of clinical research. It's not a lab or mice or some sort of equipment that's the basis of health services research. It really is talented and hardworking people. And this is the group. I didn't put all the slides. There are probably 30 more people, research coordinators, coordinating center, folks that I didn't list, but these were all the site PIs across the country that contributed to the network. And we had 6 funded projects, and that kind of listing them there, but they ranged from the environmental cleaning bundle evaluation, looking at the effectiveness of antibiotic formulary policies and the impact on C. diff, SSI decolonization bundle, urine culture policy change. So we did diagnostic stewardship. If you overculture, you overtreat. And so if you send fewer urine cultures, you'll likely prescribe fewer antibiotics. And then there was a study that looked at a spread of MDRO in our nursing home populations. And lastly, we did a study on the ultraviolet light terminal cleaning robots. And just wanted to highlight one of the first papers that was published this year out of the network. The network ended and we just started publishing, and then the pandemic hit. So there's more to come, hopefully about 10 papers or so out of the network. But this was the first one that Katie Suda and Matt Getz, they looked at various stewardship policies and how that impacted fluoroquinolone prescribing across the entire VA. It was published this year in Infection Control Hospital Epi. So again, the VA is the largest integrated healthcare system and has numerous medical centers and community living centers. And these next 2 papers really leveraged what we do with MRSA pretty uniquely in the VA system. Since 2007, the national VA system has mandated that we collect MRSA anterior nares swabs from all admissions, and then also on discharge, so we can actually look at acquisition. But these next 2 papers leverage those policies and data. So I hope someday to visit Sao Paulo, but this is a nice picture of what Iowa looks like. Actually, just maybe a few weeks ago, right before the corn harvest, you can see the dry corn there. They have to wait for the corn to dry and then they harvest it all. And I'm sure you have that in Brazil too. I don't have to say that, but this is what Iowa looks like farming. And somewhat uniquely, actually, I have this at the bottom, but we're the largest, I think, pig raisers for pork in the country, and also largest egg laying for chicken eggs in the country. So a lot of agriculture, a lot of food production here. And some of you may know there's a MRSA strain, sequence type 398, that's livestock associated. We started seeing it in Iowa in our cow production, beef production, and it's also been reported in the Netherlands and Pennsylvania. In fact, the Netherlands was a colleague of ours who, before I was here, Andreas Voss, who trained at Iowa, went back to the Netherlands and kind of discovered this pathogen spreading there. And in Iowa, there are 19 million pigs at any one time. There are only 3 million people, and there are 19 million pigs. And we have 7,000 concentrated animal feed operations, CAFO, in our state. And so we wanted to see if the food production, livestock MRSA was present in our state. And so this is a CAFO for those of you who haven't seen one. very high density. You can imagine MRSA would spread among people in this situation, so not surprising that it would spread among pigs. And Maggie Carroll is one of our PhD geography professors, and she analyzed the VA data. And this is her paper from Infectious Control Hospital at B in 2014. She looked at all veterans over a 2-year period, December 2009 to 2011, who had an admission nasal screen. So were they positive on admission? And we geocoded, in fact, the VA geocodes where every veteran lives. So the latitude and longitude. And then she excluded urban centers, so veterans that live there, because there are no farms or pig farms specifically in a city. So among the more rural veterans, she looked at the distance from the large CAFOs, the pig farms, and divided them into within a mile and greater, within a mile and greater than 1 mile from their home, and looked at how many animals were within that radius, inside the radius or outside the radius. And this is done in animal units because there's so many animals. So it's 1,000 animal units, and that's about 2,500 pigs. So among a pretty large cohort of 1,000 veterans, about 7% were positive on admission. So pretty high. In the United States, it's maybe 1% of people are MRSA colonized. So this population of veterans in Iowa has high colonization at almost 7%. And interestingly, if you had greater than 1,000 animal units within 1 mile of your home versus less than, you had a 3 times risk of being MRSA colonized in admission. Now, this doesn't prove that it was caused by the pigs or living near the pigs, but it is interesting that we were able to see such a strong association. And we're not exactly sure if it was the MRSA that was spreading off the farms or potentially antibiotics that were fed to the pigs in the effluent that was spreading in the environment that were putting our veteran patients at higher risk. The next paper leverages the similar data, and just want to make sure I'm doing fine on time. So the next paper leverages the national data and the MRSA initiative that started in 2007, but focuses on gram-negative infections, gram-negative bacteremia. And this was one of our colleagues, Michi Goto, did this wonderful paper. He's an infectious disease physician and epidemiologist here. So in March 2007, the VA initiated the MRSA directive. So this is where they mandated MRSA swabbing on admission and discharge. They isolated anyone that was MRSA positive. They hired an MRSA coordinator. So each one of the hospitals had to have a nurse infection preventionist who was focused on preventing MRSA and assisting with infection control. They also worked on a culture change and specifically focused on improving hand hygiene. They started an infection don't pass it on effort to increase hand hygiene. And so the question that Dr. Goto asked was, did the initiative impact other non-MRSA infections, particularly hospital onset gram-negative bacteremia infections that are either E. coli, Klebsiella, or Pseudomonas? And so from about 14,480 gram-negative bloodstream infections, 11,196 were hospital onset, so greater than 48 hours from admission. And then he did time series analysis, segmented linear regression, to see the impact of this initiative on the slope and intercept of the gram-negative bacteremia rates. And so this is the analysis. And so the pre-intervention period, and then there was a washout period in the middle, and then the post period. You can see that in the pre-period, there were higher rates. And if you fit a line and continue it on, you see the dashed line here. That's what would have happened if we assume if we didn't have the initiative. And then he fit a line through the post-intervention data, and you can see that gram-negative infections, even to the eye, even if you don't fit it, you can kind of see you would rather be over here than up here. And so there was a 43% reduction in gram-negative infections just from this investment in infection control. So having another nurse focusing on hand hygiene. We don't think swabbing for MRSA and isolating MRSA patients, because that's like 6% of people, would really reduce gram-negatives 43%. So this is really infection control, focus on infection control works. And it's exciting that all the effort we put in and all the hard part of wash your hands and it feels miserable, like we're not doing anything. When you see data like this, it's very rewarding. So it's a really nice paper that Dr. Goto produced. And then as a control, people could just say, well, the gram-negative infections were decreasing in the community, so you did nothing in the hospital. Well, there was some decrease in the community, but it was far less, so 14.8% less. And these were the cultures on admission. So in that first 48 hours, community onset of bacteremias. So really not as big of an effect. And so I think you can't say it's some sort of external factor like better prescribing in outpatient settings. It really is infection control. So just want to talk a few minutes about non-VA collaborations. Starting in 2018, I was lucky that the Veterans Affairs system allows physicians who've been there 10 years to have extended educational leave. And I wanted to learn more about how other places were controlling resistant gram-negatives, specifically carbapenem resistant Enterobacteriaceae, like E. coli and Klebsiella. So I was lucky to have the opportunity to do extended educational leave supported by the VA and also be sponsored by the National University of Singapore and NHS and National Center for Infectious Disease in Singapore. This is my first office there. It's a 1910 British hospital. Singapore wasn't a country until the 60s. And if you can see my cursor, this black building here, so this is 2018, my office. By 2019, my office was here, which was a brand new high rise. And it was a National Center for Infectious Disease hospital that has over 300 beds and that was modeled and built because of SARS-1. So they built a coronavirus hospital that opened 1 year before the pandemic. So talking about a country, I mean, they were really hit hard by SARS-1. They lost 10% of their economy, and they said they never wanted it to happen again. So they built their healthcare system to deal with emergent pandemic viruses. So pretty amazing place. But at the time, I didn't know, I knew they built it for that reason, but we of course could not predict that soon thereafter this would happen. I just want to highlight two papers that you can pull or email me, and I can send you the PDF if you're interested. But this is a paper by one of my primary sponsors in Singapore, Kalis Marimuthu, who's assistant prof at the National Center for Infectious Disease there. Really bright investigator. And he did a household transmission study where he swabbed people in the household of people discharged from their system to the community, and found that of the other people in the household, maybe the spouse or the children or relatives, about 10% of them got carbapenem producing CRE in the household. So there is some transmission from patients discharged. And then, let's see. And then this is another paper by Dr. Marimuthu, and then some of his mentors there. He looked at the risk of antibiotic exposure and non-carbapenemase producing CRE, and that was and also carbapenemase producing CRE. But it turns out that antibiotic exposure is far bigger risk factor for the non-carbapenemase producing Enterobacteriaceae. So really nice finding that stewardship will impact one type of CRE, perhaps not the other. And then just a few last things to mention. At University of Iowa, Dr. Goto, who I mentioned, Gosha Klor, Alex, and others, we've been trying to build a central data repository with our EPIC data. We've merged it with the University of Maryland data for some CDC studies. And then, of course, Singapore is moving to the EPIC system, so we're hoping eventually to merge data with them. And then we're collaborating with Dr. Marra to merge data of MDRO infections across all of these hospitals. And then we've had some discussions with, through some connections Lorene Herwald here has with the China Medical University Hospital in Taiwan. So I think the future is building networks and collaborations. And I think the fact that we can talk across thousands of miles on a Tuesday, Brazil and Iowa, we should be able to share data and talk like this and build collaboration. So that's the next hope for me in my career, is to help build these networks. A couple of last things, just want to highlight this journal. It's been a second home for me since 2017 when the journal started. Our first issue was in May 2018, and our recent impact factor is now 8.5. So we're really kind of a high impact journal. It's the largest impact factor for a large volume open access journal. So everything that's submitted here, even non-COVID articles, all of them are free to read by the general public. They're uploaded into various things like Apple News on an iPhone or iPad, gets all of our papers as they're published. And so this has been a great thing. And then because of these connections, I've been able to publish with JAMA some of my viewpoints. So we were, as an editor, I reviewed one of the first mathematical models, I think the first mathematical model published out of Wuhan. And my colleague David Hartley and I wrote the editorial in the main JAMA journal. And then with my colleagues here, Dan Diekema and Mike Edmond, we published a viewpoint on eye protection with face shields. And so this is just to highlight this collaboration. Dr. Edmond, I know, was a mentor and colleague of Dr. Marra, so it's nice to highlight his work too. He's a real star in infection control. And then one of the things Alex and I collaborated on around COVID was reviewing all the literature up to that point for the need for eye protection. I think it became pretty clear early on that this was an airborne virus, and so we needed the best masks possible. But things like face shields and goggles might be beneficial. And so we reviewed the literature, Alex did, and we published this letter to the editor, which has been cited pretty frequently. Not much has been written about eye protection, unfortunately, but this is a really great contribution. And then just want to highlight one other project by Dr. Goto. He looked at, he was the epidemiologist for 8 acute care hospitals and 8 nursing homes in the upper Midwest during the pandemic, and implemented really aggressive protection measures in the nursing homes. And we wanted to see how our nursing homes fared compared to community nursing homes who probably weren't as aggressive with infection control. So during the pandemic, he looked at the first 6 months of the pandemic and 20 of our nursing home units in the upper Midwest. And it's a little bit complicated figure, but these are all the things he implemented, including mandatory masks and face shields, prohibiting direct admissions from the community, visitors restrictions, and then eventually unit level screening for employee cases. But it's a little bit hard to see, but this is the number of cases per week in the community of all the states where our nursing homes are. So places like Minnesota, Nebraska, Iowa, South Dakota, and North Dakota. And then this is the nursing home cases in community nursing homes So really high number of cases. And then obviously early in the pandemic, a lot of the morbidity and mortality was in our nursing homes. And you can see here from March through the end of September, we had 0 cases in our nursing home over 6 months. So another rewarding paper. It shows if you really want to protect our nursing home residents, you can. You know, nothing's perfect. We eventually had a few cases, but over the first 6 months when we couldn't even vaccinate, we didn't even know what we were doing practically because it's a brand new virus. All of these strategies worked. And one last thing to highlight from the pandemic, just published, wanted to highlight really star investigators, Weston Branch Element at Boston University and the VA there, and Rich Nelson, a health economist at the Salt Lake City VA. They were nice enough to include me in this evaluation of national COVID data and how it's associated with opening schools during last fall. So July to September 2020. This was just published in Nature Medicine. And they showed that there was no impact really of opening schools except in the South, where they probably didn't have as good of mask wearing. But this was pre-Delta. We think the world's clearly changed after Delta. And last couple of things, we're gonna focus more at Iowa on antimicrobial stewardship. I just wanna highlight colleagues. Again, I mentioned Dr. Godo. He has 2 grants looking at antimicrobial stewardship. And Dan Laborsi, who's our antibiotic steward physician investigator, and his grant looks at improving antimicrobial use at hospitals that lack infectious disease specialists. Perhaps 10–20% of our hospitals don't have ID physicians or infectious disease pharmacists. And so how do we support those folks? And just really briefly, another collaboration with Alex, we're looking at antibiotic use during end-of-life care. We know a large amount of healthcare happens during the last few weeks or months of life. And so we're developing an intervention to target this. And the first thing we did that I'll highlight here is a meta-analysis that Alex completed looking at all the published literature on end-of-life antibiotic use. And this is, again, published Infection Control and Hospital Epi, the systematic review of 72 papers published through July of 2019. And here are the inclusion exclusion criteria. I won't spend too much on that, but of the 72 studies included, most were in cancer or dementia patients, and then there were mixed populations. And one of the main findings is that 2/3 of the studies reported antibiotic use of greater than 50% during this end-of-life period. And palliative care was associated with, when you compare it to end-of-life care not on palliative care was associated with a 73% increased odds of being prescribed an antibiotic. So there were limitations. These were not really randomized trials. 6 were non-random, 69 were non-randomized. They were moderate to low quality. End of life wasn't well defined. It could range from 24 hours to 6 months. Selection into palliative care is not random, and some hospitals don't offer palliative care, some do. And how comorbidities or other issues were handled wasn't uniform. So we need better studies, which is the plan for the rest of that grant. So in conclusion, kind of right at the 45-minute period, I think my career, I was incredibly lucky to have mentors from June Osborne to Ken Sepkowitz to Rich Platt, Ken Sands, and Milt Weinstein and Mark Lipsitch, and many others, and even colleagues that are a year ahead of me, like Anthony Harris and Mary Claire Rogman, I learned a ton from, and folks here like Dan Dikema, Mike Edmond, Alex Marra. So find great mentors. No matter how advanced you are in your career, you should still have a mentor. Before the pandemic, I would meet with our executive dean here, Pat Winokur, who's an infectious disease physician, does vaccine trial work, and I consider her my mentor here, even though I'm a professor. So never give up on finding great mentors and being mentored. Always ask questions and be curious. I think that's the fun part of what I do. So if you like that, If that's your why, then do that. And then when you get to a position where you can mentor and support people, that's really important. Always support early career folks who are reaching out for mentorship and support. And lastly, I think, and this is where I want to spend the rest of the next few years, I can't say the rest, but the next few years, I want to build more collaboration and networks, because as we've seen with the pandemic, and we've always known with resistant infections, this is a global problem, and just focusing on your city, your state, your country isn't enough. We need to all work together. So much to learn from everybody, so collaborate. So that's my VA hospital, and thank you. Can take any questions.
Well, wonderful. Thank you very much, Eli. I appreciate you for joining us at Einstein Connection. This is exactly what I was expecting. I like very much all the thoughts, and I like it because we have here fellows from Brazil, and many times they think to find a mentor if there is a lab. And I like that you said, oh, I'm not investing in labs, I'm investing in people, talented people, and hardworking people. And building collaborations, building networks, and you are very strong in research network. And that's, I admire you for all of things, but one of the things that is, from my point of view, you are so strong in research, because that point you make connections, you are your research network. And I really appreciate, because we didn't combine all your talk, you said totally spontaneous, natural, organic, yes.
Yeah.
And I really appreciate that. It's exactly what I want. And
thanks, Alex.
And I'm receiving like some comments from Brazil, like terrific talk, and appreciate you. And I just want to give some talks about here for everybody to answer the survey at the end of the presentation. If you have any questions, please send me the emails that Lord Saya share with you. A link of Eli's presentation will be released probably in the next couple of days, and we will add it in our website. To get started, I have some questions. I was really impressed about Singapore. I didn't know that this building that you were there were built because of the SARS-CoV-1.
Yeah,
that's wonderful, because these epidemiologist life from VRE to SARS-CoV-2, SARS-CoV-1. And
yeah.
what was it like to live in Singapore? Which are the positive aspects or negative ones that you could share with us?
There were almost no negatives from Singapore. I think the time difference was really brutal, like 13 hours. And I was still a editor at JAMA Network Open. And so I would have to dial in at like 11 at night or midnight for our manuscript calls and all of those other things. So maybe if you go to another country, it's nice not to be that far, 12, exactly the opposite side of the world. But the government of Singapore and National University of Singapore were incredibly supportive of me. The National University provided, I had to pay for it, but they provided affordable housing. And there was a community with all sorts of professors from every field. All of the visiting professors in National University of Singapore were in this kind of one area that I probably shouldn't be. And so even when we were at breakfast, we could have discussions, with a history professor or an English professor. So those are the best. But then I focused my first few months. I was supposed to go back for 2 more months, but the pandemic prevented that. But the first 2-3 months, I spent a month at each of the major hospitals. And I was a visiting ID fellow. So I would be on rounds and see cases. And I wanted to see how they practiced infectious diseases, and also how they practice stewardship and infection control. So I was more like an anthropologist, an untrained anthropologist, watching the practice. And so seeing at Singapore General Hospital, which is downtown, one of the main city hospitals, Tan Tock Seng Hospital next to NCID, the National Center for Infectious Disease. That was the original Chinese hospital, big 2,000 bed hospital. And then National University Hospital system, which was the system like the University Hospital of NUS. So I was able to meet all of my ID colleagues at all those places, go to citywide rounds. And so I mostly just learned how they practiced ID. The last 2 months I was supposed to do more research and building more networks as they transition to the EPIC system, but I didn't get to go back in the summer of 2020. So hopefully I will go back soon. But just amazing colleagues, they see, I'm sure, just like you in Sao Paulo, amazing infectious diseases, very different, things like amyloidosis, there's a ton of tuberculosis. So I just saw, much broad range of their day-to-day life, which was fantastic.
Probably dengue.
Yeah, there was actually a dengue outbreak when I was there. Yeah, I actually think my oldest child got dengue when we were there.
Wow.
So, but fortunately, first time and not very sick.
Yes. I have a question in the chat. Considering the antimicrobial stewardship, what are your thoughts about the pharmacist contributions in this field?
Yeah, I can't speak for any other, maybe just Singapore and the US, that's all I really know, but we have to work with our pharmacy colleagues in stewardship. And so in Singapore, there's one ID physician and something like 9 pharmacists at their Singapore General Hospital that evaluate the cases every day. So they get the computer printout and evaluate them. And so the teamwork is critically important in that. So I think any system needs to be tailored to the local context, but at least in the US and Singapore, the collaboration between physician and pharmacist is critical.
There is another question here. Are you available to accept international fellows in your department?
I think so. We have had numerous international fellows, like Alex being one. But yeah, we've had fellows from Saudi Arabia, from Spain, other places. So yes, it's difficult right now, I think, in the pandemic, but hopefully soon we can open things up.
But considering, for example, pharmacists, are you available? That's the question for a pharmacist.
Yeah, I think so. Yeah, I mean, I think we would want to make sure that the pharmacy colleagues would also be available to them. I think that would make it more worthwhile. But there's nothing about your degree that you could still be a fellow in internal medicine. Even if you're a pharmacist or have another background.
Oh, wonderful. And what are the possibilities to get financial support from a US department, for example, considering your researchers or your research when you apply for a VA grant? Is it possible for an international fellow to be part of that?
It's trickier. You have to be a US citizen or to be appointed in our VA. I don't necessarily, I don't set the policy, but that's just what the policy is. There are kind of other ways, but typically for a visiting fellow, they would be at the university, and then we would have to plan ahead. We do have resources that can be supported on these grants through contracts to the university, so things are possible to get some funding. We were able to pull some support for one of the visiting fellows for a brief period from Spain, but it takes a lot of planning. So the answer is yes, but it takes planning.
Yeah, no, but I think that it's a good question. And to be clear that it's much easier to get the financial support from Brazil to go to the US, for example. I think that it's good because many times people, I heard, like, oh, let's try NIH, let's try CDC, but if you are not a US citizen, it's not possible. I think that it's totally interesting, this question, because you cleared very well for us. And maybe if we can find a solution in the future, like merging data, collaboration together, we can take grants from Brazil or from US to get support for an international fellow. Yeah, I think that's pretty interesting.
Yeah, that is a good point, though. Eventually, it would be great if we could figure out having CDC and maybe the government of Brazil collaborate on,
Yeah.
dual funding for these kind of efforts, because everyone's restricted. Like, it would probably be hard for the Brazil government to pay a US citizen. And it's just sometimes, the governments are very specific. Not that they should be this way, but just because the politicians, want the money to go to the people voting for them, I guess.
Sure,
that's
exactly,
the problem is. But if there's a collaboration or a network that could be built, we had the VA, which is a totally different agency, fund part of our network, and the CDC, a totally different agency, fund the other part of the network. So we found a way for them to collaborate. So maybe Brazil and the US.
Oh, wonderful. Well, Eli, thank you very much. We have 2 minutes. I didn't see any other question, but only saying appreciate, very nice lecture. Congratulations. And yes, thank you very much. I really appreciate. And it's a privilege to have you here with us in São Paulo, Brazil. And I hope that in the next years, we can invite you again to join, because your presentation was very, very, very inspirational. Thank you very much.
Oh, thanks, Alex. Thanks for inviting me, and hope to meet you all sometime in Sao Paulo.
Thank you. Sure.
Take care.
Bye-bye. Take care. Bye-bye.
Bye.